Hello, everyone. My name is Murk Memon. I'm one of the rheumatology registrars. First of all, I would like to thank BSR for giving me the opportunity to present this interesting case. Secondly, I would like to thank my consultant, Dr. Jeffrey, for her help and her guidance. I'm here to present a challenging case titled Diagnostic Dilemma with Lung Cavities, a case of ANCA vasculitis with concurrent Actinomyces infection, diagnostic and therapeutic challenges. Cavitating lung lesions present a wide potential differential diagnosis, including infection, malignancy, infarction, and autoimmune causes. With the presence of ANCA, this increases suspicion of ANCA-associated vasculitis. When infection presents concurrently with ANCA-associated vasculitis, early diagnosis can be challenging and can create diagnostic uncertainty and complex management dilemmas requiring careful multidisciplinary evaluation. Our case involves a 28-year-old male who presented with pleuritic chest pain, sinus symptoms, episexis, hemoptysis, and night sweats, along with weight loss. Initial examination revealed mild throat erythema. Investigations showed inflammatory response with leukocytosis, neutrophils, mild eosinophilia, deranged liver function test, and elevated inflammatory markers. Renal function was, however, normal, with the urine dip positive for 3+ blood. Cultures were negative. Rest of the blood tests, including immunoglobulins, hepatitis B, C, and HIV, was negative. Imaging in the form of chest X-ray and CTPA showed multiple bilateral cavitating lung lesions, nodules, and hilar lymphadenopathy, raising a strong suspicion of ANCA-associated vasculitis. Crucially, he tested strongly positive for C-ANCA with NT-PR3 titer, initially leading us to suspect ANCA-associated vasculitis, for which he received prednisolone and rituximab. However, further investigations with bronchoalveolar lavage histology surprisingly revealed filamentous bacillary colonies with central eosinophils identified as Actinomyces species. This discovery prompted a significant shift in the treatment, pausing steroids and starting high-dose antibiotics. Despite this, his clinical condition deteriorated with worsening lung lesions, rash, renal impairment, and rising PR3 titers. A repeat lung biopsy confirmed necrosis and fibrinoid changes, indicating active vasculitis. This led to restarting immunosuppression with cyclophosphamide alongside ongoing antibiotics, ultimately stabilizing his clinical parameters. This case highlights the diagnostic and management dilemma with lung cavities and ANCA-associated vasculitis when infection co-presents. Pulmonary actinomyces can mimic ANCA-associated vasculitis features, presenting with tissue breakdown and granulomas. The overlap is significant, and ANCA antibodies can even be positive in the presence of infection. This made definitive determination of the primary pathology incredibly difficult. Given the patient's severe clinical deterioration and progressive organ damage and involvement, our multidisciplinary team decided to treat both conditions simultaneously. This pragmatic approach prioritized patient safety over definitely unraveling the exact relationship between the two pathologies. Our key takeaways are, firstly, pulmonary actinomyces infection is a rare subacute opportunistic infection and can present similar features to ANCA-associated vasculitis, causing diagnostic dilemma. The interaction between the two is uncertain. Lung cavities with ANCA-associated vasculitis may be associated with infection, and screening for infection should always be carried out. Secondly, ANCA-associated vasculitis and serious infections can present simultaneously and may need a concurrent treatment plan. Thirdly, negative microbiology screening does not exclude infection, as demonstrated by subacute identification of actinomyces despite extensive workup. Therefore, multiple sites and repeated tissue sampling would be crucial. Finally, complex cases like this demand an essential interdisciplinary MDT management and a willingness to intervene based on probability and risk assessment without absolute certainty. Thank you very much.